Yeah, that's just so we get an attendance list at the end, so we know if people actually showed up or not. So. Yeah, of course. I should see a notice come up that you are. No, well, I think you and the other presenter, he's on my other screen, so you're the only two up so far. Oh, hold on, I just had to click admit and I will let you in and you should be in the session. I just had a shower, my hair's still wet. No one will ever know that. No, so I can make you, I'm just going to pause the record and go.
Morning, everybody. I'm going to just try to share screen here. Can you see that? Somebody give me a thumbs up. Everybody see that okay?
It's perfect. It's perfect, Ray.
Oh, okay, thanks, Tom. Well, good morning from White Rock, British Columbia. It's finally light. I am pleased to be here. The information that I'm going to be presenting will be new for some of you, and for some of you, it'll just be a little bit more about recovery coaching. I hope it's useful. In this brief period of time, it will be a 50,000 foot, really quick overview, and it may precipitate as many questions as it answers. I'm going to go as quickly as I can effectively do, and hopefully we'll have time for questions. If you ask your questions early, I'm not going to see them. I'm technologically not exactly talented, so I'm going to try to look at the chat at the end, and if there's questions I can answer, I will selectively answer them. So let me just talk a little bit about myself. I'm a retired family doc, 10 years as a family doc, and then 30 years worked in the field of addiction medicine, occupational addiction medicine. I retired in 2015 from active clinical medicine, but all my career, I was a medical educator, medical researcher. Since I retired from clinical medicine, I focused on recovery science, recovery medicine, recovery-oriented systems of care, and with a specific focus on recovery coaching. And I took the training and became a trainer, and have actually written a curriculum on recovery coach training. I've been married for 51 years. I got grand twins, and if you ever ask for pictures, I'll keep you busy for about an hour. I'm a marathon runner and endurance triathlete with a bad knee, so I can't do Ironmans for a while. I've been in recovery from addiction for 36 years, and I'm not receiving remuneration for this, and I'm not selling anything, so I don't have any conflicts of interest to declare. Although I'd really like to see a lot of you get involved with recovery coaches, and if you don't get involved, learn about them so you can use them, because they're very helpful in making your job better. This is only half in jest, this cartoon, but it represents sort of my medical background. In mainstream medicine, we focus on the diseases, and we work on addressing diseases, fixing diseases, as if that would produce health, and it doesn't. What's more, with chronic diseases, most of our interventions are at best Band-Aids. The thing about addiction is a lifestyle medicine condition. It's just like heart disease, diabetes, many other multimodal, multi-caused conditions. It is chronic, and the main part of management of the disorder is long-term, in the community, with your family, in relationships, modification of your life. And it's the same for diabetes and heart disease. So the shift was a welcome one because I'd become more and more frustrated. These are exciting times, folks. Mainstream medicine is waking up, partly because they've realized it's not sustainable. The current system of care can't be sustained because obesity, type 2 diabetes, hypertension, heart disease, and as the population ages, we've got a crisis on our hands and something's got to change. So we're moving towards recovery-oriented lifestyle medicine, giving more power to people, letting them earlier on take more responsibility for their own recoveries from all of their diseases. The same thing is happening in addiction. And so this is a very, very exciting time for me to watch. And those of you in this room who are in recovery, I'm not going to be telling you anything you don't know about the journey of recovery. But recovery is recovery, whether it's diabetes or heart disease. And so strap on your belt, here we go. We're going to talk a little bit, just touch on the epidemiology of the problem and the population of recovery, which I think might be surprising to some of you. A little bit about what moving towards recovery-oriented care. It doesn't mean giving up what we got. It means adding to. It's not either or, it's yes and. We'll talk about what the vital role that recovery coaches can play, and just begin to touch on is it effective? What's the evidence show? This is a pictograph of current data from the United States and Canada, looking at, I'm just going to see if I can get rid of this. I've got something in the way here that is blocking my slide. Here we go. So this looks at the prevalence of substance use, and it doesn't include nicotine or smoking, but it does all other substances. And at the bottom of this iceberg or pyramid are the 40% of Canadians and Americans who are 40% of our population chooses not to use anything. Now that includes those of us, the 9% of the population who had a problem and no longer do. But many of them consider themselves in recovery. And then we've got this large population, some of you in this room, who can use alcohol. You can even smoke the occasional doobie. You don't have a problem and you don't meet the criteria for addiction, and it doesn't cause negative consequences. And so now we've accounted for 85% of the population. The jump, that part of the pyramid between users and mild substance use disorder, are an interesting bunch because they're largely invisible. And you don't see them in your practices, and I didn't see them in my practice, but if they have enough what we call recovery capital, and if you went to Jennifer and the recovery session yesterday, you know all about it. They got well on their own, or they went to a few meetings or kept going to meetings, but they didn't surface in the system of care. And then as the pyramid goes up, you'll see on the right-hand side of the slide, the intensity of intervention goes up, because these are people who already tried to quit on their own and get into recovery and failed. And so if you work in the system, if you work as an inpatient treatment program person, or even as an outpatient counselor, you're seeing what we called you're seeing a bias of patients, which gives you a little distorted idea of what addiction looks like. If you watch the news and read the newspaper, many people think addiction looks like homeless people on the street, but we know that that's 0.2% of the population. And it's really not significant from an epidemiological point of view. It's very significant because of all of the related tragedies. But So this is a really broad spectrum with many different approaches required. As you go up to the tip of the pyramid and severity of addiction goes up, quantity of recovery capital is down, the presence of comorbidities such as psychiatric and medical problems, emotional trauma is more likely. And so the duration, intensity, and number of modalities of treatment increases. Hope that makes sense. So what is recovery? Now, many organizations have made the attempt to define recovery, and in general, they overlap in certain areas. Recovery from anything, whether it's heart disease, hypertension, diabetes, or addiction, part of it includes remission. I didn't say abstinence, I said remission. So the criteria for addiction are no longer being met. In other words, this person no longer is experiencing negative consequences, loss of control, compulsive use of their substance or behavior. And that's the nice thing about these definitions. They can also be used as objective, measurable outcome measures. So we can chart how well we're doing or how well our clients are doing. And with the other chronic diseases, there's improved health. With addiction, it's kind of miraculous. And I'll show you from our life and recovery surveys. So people in recovery from addiction have measurable increase in mental health, physical health, their level of function, either interpersonal and relationships, at work, at home, whatever they do, improves. And there's more social involvement. There's less involvement with illegal behaviors and way more involvement. As a matter of fact, people in recovery are more likely to donate and to volunteer and to work with others. And that kind of leads into recovery-oriented care. Because if I was the government and I found out about an army of largely invisible people out there who volunteer as part of the recovery, who we could mobilize and put to work to deal with the problem of addiction, I'd be interested, because it's like the sleeves of the vest. It doesn't cost anything, and they're out there. They're all around us, but we largely don't see them. In 2015, I was involved in the Canadian Centre of Substance Abuse, and has now changed its name, Summit on Addiction. And we created the Life in Recovery Survey. I helped design and interpret it. And it was meant to closely resemble those similar surveys done in the United States, UK, and Australia. We got a pretty good representative using a snowball approach, people who know people inviting people to do an online survey. We got 855 people, fairly representative of people who identified as being in recovery. And we had about 9% were Indigenous First Nations folks. And they filled in this. It took 45 minutes to fill this out. It was a pretty big commitment. And those who did it reported markedly improved quality of health, quality of life. You know, their use of emergency department and health services went way down. Everything got better for them. It's really interesting that when they identified resources that they used in order to successfully recover, the average was 6. Now that includes treatments and outpatient counseling, but it also includes things like an exercise club or whatever other resources that they identified. It might have been a writing club, but it usually was interpersonal, and it was activities to support their recovery. And another myth that got busted, the top barriers for getting into recovery were not lack of adequate services. The top 3 barriers were internal. They were, I didn't know I had the problem. I didn't know anything about addiction. I didn't think it was serious enough. I didn't have hope. I didn't see any recovery hope. So I didn't even know it was possible. And I felt ashamed because of the stigma. So here are some, this is just some data from the Life and Recovery Survey that we picked out. And these are the therapeutic activities. The percentage of our population that used them is the left-hand column. Of those who used it, if they rated as very important, well, that's the percentage who rated as very important. So I suppose it's not surprising, 90%, 92% of them have tried a 12-step program, and 80% of them rated it as very important. A surprisingly large number of the respondents, and that may have been a sample bias, had gone through some form of residential treatment, 61%, and 83% found it extremely useful. And so all of our modalities, or many of our modalities of care, are there. If you go down closer towards the bottom, you see medication, second from the bottom, medication-assisted treatment. So we had 20% who were treated with medication. And of those, some of them found it very important, but it's interesting to compare that to the other modalities of treatment, like the talking therapies, the interpersonal therapies. It's less than that. And for the very bottom bullet, remember I said 9% of the respondents were Indigenous. 5% of them of the whole population of respondents found their way to Indigenous programs. And most of them found that very, very helpful. Okay. What's wrong with our current system of care? Well, it's still somewhat based on an acute care model, as if addiction was something that you could cure or fix. And it's not that appropriate. So we sit in our silos of specialized treatment, and we do a really nice job because we're doing something that works. But the problem is that there's gaps between the silos. And so people fall between those gaps and they don't make the transition to the next step in their recovery. And I know there's people watching this saying, hey, wait a minute, I connect with the families and the community all the time. But generally, and I appreciate that you do, but generally the system largely neglects families, loved ones, allies, communities of recovery, mutual support groups like Smart Recovery, Women for Sobriety, She Recovers, 12-step program. And the other thing is this insane tendency in all of medicine. I've never seen a group like it, that we in addictions circle the wagons and then point our guns inwardly and shoot each other. So the mental health people and the addiction people, treatment people don't get along. The harm reduction people feel alienated from the rest. The medication-assisted treatment, whether it's buprenorphine and methadone or naltrexone or whatever, and then the abstinence people are off to the side, which is such an insane waste of effort, because we all need each other and we all do different things and we work at different stages with different people. And we really, really need to learn how to play in the sandbox together. Here's something you may not know, because you get to see the people who the reason you see them is because they're not in recovery. But of all the diseases that are chronic, progressive, potentially life-threatening, addiction has the best prognosis. 75% of people with addiction are going to recover. That's evidence from a number of really solid scientists. So as I said before, when epidemiological studies have been done, and there've been a number of them, if you sample the population, 9% of people once had an addiction and no longer meet the criteria. Now, the people who quit on their own when they were 25 years old, and their partner said to them, either you quit or I'm out of here. So they quit, and they had enough recovery capital to do so. they may not consider themselves in recovery. They just said, no, I don't drink. Bad things happen when I drink or use that cocaine or whatever. And so they don't identify, but it's generally higher than we think. And because of stigma, they are largely invisible. And not just stigma, people in 12-step programs misinterpret the tradition of anonymity and say, no, I keep my identity to myself. And that's meant to protect the program, not meant to, I mean, we really need, let me tell you, for 8 years in a row, I ran the Boston Marathon. And for those 8 years, all the way along the course, I'd be cheered by 30,000 spectators. And many of those spectators would be holding a sign and wearing a funny costume, as were the runners. And they were in support of one of the chronic diseases, one of the cancers and diabetes, name it. The advocacy groups were out there raising funds. How many people do you think I saw that were holding signs saying support addiction recovery? Yeah, not one. So we need advocacy. We really need to get out there with the good news and let people know there's hope, that addiction is a chronic illness. People don't set out to get it, but most of us can recover, and we can recover a lot easier than we do if we just lower some of the barriers. So now the third bullet should be an eye opener, the third and the fourth, for anybody who works in the field of addiction. And this is from LIT, and it's solid research. If you link your client with addiction, if you link them with another human being who's in recovery, you've just increased their chances of success in reaching sustained recovery by somewhere between 17 and 27%. That's higher therapeutic benefit than you'll get from just about any other treatment. If a drug came along with that kind of a benefit, the makers would be multi-billionaires. So if you're not hooking people up with people in recovery, learn how to do it and start doing it. And Kelly's meta-analysis in the Cochrane Review, looking at hundreds of thousands of patients or clients in many, many research studies, showed that 12-step mutual support groups work at least as effective as any other treatment for alcohol dependence. And we suspect it's true for other addictions. So, and one of the things I was watching the chat yesterday, and people who are unfamiliar with 12-step groups were saying, yeah, there's a religious overtone, absolutely. And there's bad people and stigma and harms that happen. Well, yeah, that happens pretty much anywhere in a place where you get a bunch of people together. But generally, the efficacy of 12-step groups is pretty hard to dispute. And the other thing is, in Canada especially, the most rapidly growing mutual support group is secular AA. And if you want to check it out, go to one of the websites, AA Agnostica or something. And secular AA is anti-dogmatic and it's anti-religion. But it's very, very pro-recovery, a very exciting, vibrant community of recovery. So you probably already know about Recovery Capital, but Recovery Capital are those things inside of me that I really don't get credit for most of them, because being a privileged white male from a middle-class family who got education, my recovery capital was very high. So my recovery was relatively easy. But it's all of those physical components, emotional, social, family, community, spiritual, educational, that help me deal with my addiction and enter recovery. There are now some good psychometrically validated instruments to actually identify the components, to measure them. And if you're not using them, look them up. Look up either the BARC, the Brief Assessment of Recovery Capital, or the Short Assessment of Recovery Capital. They're both free. You can use them with your clients. More importantly, you can give them to your clients, use them on themselves, because they're very, very helpful for charting where they need to work on themselves and how they're doing. And by the way, I've been in recovery 36 years, and my recovery capital scores continue to change, and they're not going down. So as long as I keep doing the things I need to do to continue my growth in recovery. So they're very good. They're a game changer. They're very helpful. When you first see a person, when you first do that intake interview with somebody who's really sick and toxic with their addiction, even then you can get an idea from their recovery capital, from just a snapshot, what their initial needs are going to be, a little bit about what the chances are of immediate success and the level of care that they need. So it's a game changer. It's really important. What needs to happen to go from active florid addiction to recovery? It's simple. People with addiction just need to build a recovery capital because everything's in there. Same with recovery from diabetes. It's not rocket science, but they need connection. And of all of the activities that you can do with people, it's if you can connect them to the community of recovery, bingo, that's the big one. And as Mary Leamy, the CHIME acronym, the bottom bullet here, came from Mary Leamy, a researcher in mental health issues, identified those components that predict successful recovery from mental health disorders. And CHIME, most of you probably know this, stands for, the C is connections, the first item. You connect them with their peers who are ahead of them in recovery, and that instills a hope, which is the second one, hope for recovery. If they can see there's a chance for hope for a better life, to get out of this endless cycle. I is identity. We need to be able to identify with a new, with a group, with a tribe, or a community, or a group that we feel good about, that we feel comfortable with. So when you're referring your client and hooking them up with a mutual support group or with a other community program, it's important that it match, because if they can't identify, they're going to walk away and say, I guess that's not for me. So that identification is really important. It has to be people who look and sound like me. And that's why you want to make connections with a diverse population of people. So if you've got members from marginalized groups, you can help them find their tribe, their own group of people in recovery. M is meaning. As human beings, we require meaning in our life. So as part of my recovery, I'm going to have to look at my values and my goals and set my sights on something of meaning. And empowerment is where we take, and it's something that we in the treatment and therapy fields sometimes aren't very good at, and that is giving the baton to the patient, to the client when they're ready. We empower them to take it as soon as they possibly can. In other words, work ourselves out of a job and make them, give them agency or autonomy over themselves. What a recovery-oriented system of care. What are the components? Well, you're the number one part. That's all the existing treatment providers. So that's addiction counselors, outpatient treatment, inpatient treatment, residential, harm reduction, medication-assisted treatment. They're all part of it. So is the mental health system. Family and volunteers play a really key role in a ROSC. And mutual support groups and communities of recovery, which might be bigger than mutual support groups because it involves faith-based groups. So you can find communities of recovery all over the place, but they're largely invisible. It takes a while to identify them. I'm going to make a pitch for recovery coaches because they're the missing connector in all of this. But there are some really exciting components that are being developed around the world in the UK, United States, Australia, and now in Canada. Recovery community centers, which are very special places in the community where people can connect and hook up with what they need for their recoveries. There are recovery houses which are supportive of recovery. They're not treatment, but they are safe and they provides the basics. There are several now Canadian campus recovery programs. The problem with recovery schools is they come and they go. They require a lot of energy. We've had them in Ontario, but I'm not sure if we do right now. And more workplaces are realizing that that it's in their interest to be proactive about addiction, because 70% of people with addiction are currently working. They make great employees. If they get into recovery, you can't fire them even if you want to, because they got addiction, simply because it's a disability and human rights protects them. So you might as well help them identify, come forward, get into recovery, and then support the recoveries. And more employers are catching on to that. So what's a recovery coach? And Bill White, it is a little bit overly simplified, but Bill White coined this: a person who helps a person in recovery remove obstacles to their recovery, linking them to community resources, including peers, acting as a guide, a mentor as they negotiate their recovery journey. It's not a counselor. It's not a therapist. So three-way connectors. The first and most important connection is to the individual who's suffering. And that's really, really key. It means addiction is a disorder of isolation. So overcoming that initial barrier, and that can be the toughest job of all for the coach. And then helping them do an assertive link to the resources they need, get them into the assessment, the triage, the harm reduction, the whatever, the detox treatment, but get them into the system of care, and then be around, stay loosely connected. You're not going to meddle, because coaches have nothing to do with treatment, but be there to make the bridge and take them as they're coming out. Or if they get kicked out or if they relapse, the coach is still there to walk beside them in the community and connect them to their community of peers, the recovery community. The role models, large numbers of them are in recovery, but you don't have to be in recovery. You still need to be a role model. You still need to walk the talk and model healthy behaviors. They're motivators, so they do have a few interviewing skills, like basic motivational interviewing, not for therapy, but basically to help move the person and keep them motivated and keep them setting goals for themselves. They model good boundaries. And that's one of the things when we're training coaches, one of the key skills is if they don't have great boundaries, they need to develop them and model good boundaries. Addiction is full of boundary problems, in its people who suffer from it and people who get involved in working in the field, because those of us from addicted family systems are attracted to addiction services like lemmings to the sea. We're agents of agency. So our job is, the coach's job is to help move first of all, the dependents. The power greater than themselves is the drug at first. Next, it's the therapy provider. So the person is dependent on the therapy provider, but they got to get past that. They got to get past that dependency and take over agency and become responsible for their own care. And that's self-efficacy. The resource finders. A good recovery coach knows every single resource in the community, including social enterprises and places, and how to get your driver's license back, and where the good mutual support group meetings are. And they advocate in three ways. They advocate, they advocate for the individual, and to them, they're often advocating having more confidence in the individual than the individual has in themselves, but they advocate for recovery coming forth as and they advocate for the recovery community to help build this movement. So that's two columns. Recovery coaches, look at the right hand side. We are not diagnosticians. Recovery coaches don't make the diagnosis. They don't intervene. They don't treat. They don't use psychotherapy. And this is where it gets difficult. If you're an addiction counselor, or even worse, a physician, and you're trying to learn how to be a recovery coach, it's hard to let go of taking responsibility, giving advice, prescribing help, being a case manager. And those aren't your jobs. If you're a recovery coach, you're not in charge. Your job is to be a mirror and a set of tools, basically. So it's a difficult one. Some people just can't make that distinction and can't cross that bridge into so you have to be able to accept the multi-pathways of recovery. If you are an AA sponsor and you become a recovery coach, you think, I know the best way and I'm going to get people into the program. Well, that's not a recovery coach. That's a sponsor. That's an AA or 12-step worker. This just is a depiction of the system as it's out there. We have a number of services, and addiction counselors are on the right, along with other modalities of addiction treatment. On the left of the services is the harm reduction, which can serve as an entry level into the system of care. Person with addiction is out there. What are some of the entry points? Well, self-referrals, emergency department, drug courts, corrections, employer schools, outreach, intervention, employee assistance program. And we mustn't forget the police, even though they're not very popular right now. Police are a key player. Every country that has successfully dealt with the open needle drug use in the cities has always used enforcement, because police know these people, they're the multiple offenders, and police like to get involved. And if we give them a way to engage in the system, it's a win-win-win situation. And that's what they did in Switzerland, Portugal, and lots of other places. On the right-hand side is the recovery ecosystem, which remains largely invisible, but and it's growing rapidly. But there are many resources out there that support recovery. But people with addiction or early recovery don't know about it, and they need to get connected to them. And largely, the treatment services don't connect them. And that's where the recovery coach comes in. So they connect with the person, and more recovery coaches are being employed in emergency departments and primary care, medical offices. I should have put doctors in there. And in drug courts. So more and more, and in treatment centers. So there's more and more places that recovery coaches are being employed and engaged with the person. They can interact with all of the service providers, and most importantly, they can become aware of the components of their own recovery ecosystem and tie in with them. Now, this is on the evidence, and it's from SAMHSA, and we've developed some more, and every study, and Alexandra Lodad and a few others have done the research, but there's problems with the research. All the research that's out there shows recovery coaching works. It improves treatment. It improves retention in treatment. It improves hooking people up with resources in the community. Their substance use diminishes. They're more likely to keep their housing and not get kicked out. They're less likely to end up in jail or in the emergency department. They're less likely to relapse. And so, but here's the problem. Recovery coaching is so difficult to research. Think about it. I got a slide on it. So recovery coaching is sound. It's based on, when I wrote my curriculum, I identified 10 theoretical models upon which recovery coaching is based. And the emerging field of positive psychology is a big chunk of it, but there's many other theoretical models, a social identity model of recovery, and the techniques. So it's not doing anything that's new. In that way, it's not a pioneer. It's evidence-based. here's the problem with the research. There are people out there, if you go out and say, I want to find a recovery coach, you're going to find somebody who's doing something that isn't recovery coaching. It may be intervention, or it may be emotional trauma therapy, or it may be a person who's getting paid to be an AA sponsor. And that needs to change. And because it harms everybody, it harms the client most of all, but it harms this new emerging field. And it means you can't measure it, because you need to have standardized treatment if you're going to try to do research on it to see if it works. So we need manual-based, standardized, randomized control studies showing the efficacy of recovery coaching in various settings. However, the evidence to date appears to support recovery coaching as important, and it improves the outcome of everything you're doing out there. So recovery coaching isn't a either or, and it doesn't compete with anything you're doing out there, but it's an addition to. It's very fragile, it's unregulated. People don't know what recovery coaches are, what they do. There's great potential for exploiting, especially without a code of ethics and high standards. And everybody stands to lose unless the bar is raised. And that's where CACCF is taking, they're taking a role in raising the bar. This is, I'll just close with this and then we'll open it for questions. I know some of you know this story, but I really like it. So this addiction counselor who'd been a good person all her life dies, and she's goes to heaven, and St. Peter meets her, and I know she's agnostic, but go with me on this one. And she's going to her lodging, which is heaven, and St. Peter says, "Oh, we're going past the other place here. Do you want to have a look and see what you missed?" And she says, "Well, yeah." So St. Peter opens the door, and in it are a bunch of cachectic, unhappy, desperate people sitting around a table. Unlike this picture, the table is covered with rich food, but they can't, none of them is eating. They're all starving to death. They all have a spoon, but it's a long, long spoon, and they can't get it to their mouth. And it's miserable. They're not happy. And so St. Peter moves on, and they go to heaven, and it's very similar. It's a big table. Everybody's sitting around. They all have a long spoon. There's a lot of rich, lovely food in the middle of the table, but everybody's happy and fat and healthy. And of course, what they're doing is they're using their spoons to feed each other. That's what we have to do, folks. We really have to work together in this field and stop shooting each other. Okay, I'm going to now. And this is what CACCF is doing. They've assigned Jennifer Daly, and this is part of her portfolio, is to look after recovery coaching. They're establishing and accrediting training in recovery coaching, and they're establishing credentials for certification in coaching. So this is good. We really need an oversight body in this field. Okay, I'm gonna go back. I'm gonna open chat, and now is your time to put in questions. We've got a okay.
Just a reminder for everybody, if you're not putting anything in the chat, use the raise hand feature there so Ray could see you there. And we'll let Ray call upon you there and unmute yourself.
The problem with raised hands is I can only see 16 of you. There's 98 in the room. So, so it might be.
We'll help you out with that, Ray.
Oh, okay.
Okay.
Cool. Yeah, great.
Hello, Ray.
Yeah.
Dennis here.
Hi, Dennis.
Where's the hands at?
God, you're asking the wrong person.
Well, anyway,
Oh,
I'll
I'll take your question, Dennis, and then I'll go to Jennifer. Go ahead.
Okay, no, I just want I'm a counselor. I say I'm a counselor. And now I think I'm going to have to tell people I'm a coach, because I always tell my clients, I'm not here to be critical of you. I want to be supportive. I'm going to present information here. And if you can receive it and utilize it in your life, hopefully it'll make your life better. Is that what, would you say that's a fair thing for a coach to do?
Well, I would say that you're doing something really good, Dennis. And I would say that that's very similar to what I used to do as an addiction medicine doctor when I was doing primary care addiction medicine. I would offer myself as a mirror and a set of tools, but I was wearing the doctor hat. So I had that authority, and my roles were really clear, that I had that authority. So it never changed. I was the doctor, but I was using some coaching techniques. And what I'd say, Dennis, is you're very effectively using some coaching techniques, but you're not a coach. A coach doesn't have, a coach enters into a negotiated relationship with somebody where the boundaries are negotiated and laid out what each person will do. And so if the person actually has a need for some counseling partway through, I can't, or some medical advice even, which for me is really tempting. If I've done that recovery coaching role, I need to remain in my lane. And so, because it's a violation of a code of ethics for me to play those multiple roles. It's just too confusing. So
Yeah.
And when that's why I said it's hard if you've been a counselor or a doctor or a therapy person or a sponsor to learn how to be a coach, because a coach, your job when the person has those needs, even if I've got the specialized skills to provide them, if I'm the coach, it's my job not to provide them, it's to hook you up with somebody who can. So I can do the really important role of being the coach, and somebody else can do their job. Does that make sense?
Yeah, sure. That's good.
Okay.
Now, the other a question is recovery capital and values.
Yeah.
I always tell people to refer to their values, because sometimes they can go back to their families and say, yeah, I got this stuff.
Mhm.
And there's other people who say, I've lost it. I didn't have a father. My father
Right.
was a drinker or whatever. I never got fatherly roles and stuff like that. So that was a good support. And the final thing is, in Australia, they call a program called the SHAC program. Have you ever heard of that?
I have not.
Yeah, that's where they take say a retired carpenter. He'll set up a shack. He'll invite people from that community if they want to come and work with them. They may have an addiction or something, but they have them work. He shows them how to be a carpenter, and then he gets the people from the community to come in to bring their things that they need to be repaired. And there's a work together. And then every month or so, they'll have a get together in a community hall about where people have benefited from this.
And that's a great example of a specialized recovery community center. And they're springing up. They've been around forever. And Alano clubs are sort of a variant, but there are many generic recovery community centers, some of them based around social enterprises, where a bike mechanic shop becomes a place where people can develop the skill. People in early recovery come in, develop the skills. In the meantime, they're getting mentored by people in recovery. And so, in Calgary, there's what's called the Recovery College. And people in recovery from mental health and addiction come in and learn life skills, boundaries, non-chemical coping skills, being taught by other people, other peers in recovery. But it's a hangout for people to come, develop skills, and get together and develop that social network. I'm going to move on. There's other people with their hands on.
Thank you very much.
Thanks, Dan. Yeah. Jennifer, could you unmute and ask your question?
I think part of it just got answered because I am in Alberta, I'm in Calgary, and there's peer navigators, and now we're hearing a lot more about the recovery coaching. with the recovery coaching and being able to be part of a professional body, will they be able to, is it a consulting fee if they're going to be working with treatment centers, or is the idea to employ them? And it's, I guess where I'm getting stuck with, if we have outreach workers that could have the recovery and coaching pieces, but what I'm hearing you say is that there is still a slight difference with that. Did I even say anything? I got three things swirling around.
No, you said a whole bunch of stuff, and I'll try. First of all, remuneration varies tremendously. And remember, this is a 50,000-foot view. And when we're training recovery coaches for various positions, we give them 50 hours of training. And part of that is how to work when you're embedded within an agency, because it affects everything. And remuneration, you may be put on you may be on salary, you may be following their policies and guidelines. But if you're an independent professional recovery coach, it's fee for service. And so it varies tremendously. If you're in an emergency department, you're within a health, with all of the implications of being part of the system of healthcare. So there are many different models for utilizing recovery coaches, but it doesn't change what they do. The outreach workers have a different job than recovery coaches, and peer navigators, they have overlap, tremendous overlap, and they're doing some of the same services, no doubt about it. You know, a big part of a recovery coach's job is navigation, but their curriculum of things they do is broader than just being a peer navigator. So I hope that helps. But what they'd be doing is it would be really, really good if our harm reduction community were hooked up with recovery coaches, so that one of their access points for recovery oriented harm reduction is if their client, their person that they've interacted with is at all interested, a really good next step would be to hook them up with a recovery coach. And the recovery coach could take them from there and make sure that they stay engaged with something, with the system of care, and also with the community of recovery for support. Make sense? Okay. I can't see other questions. Okay, I'm going to wrap it up here. I don't know if I can go back to my session. Let's just see if I can. This is weird presenting on a Zoom call, because I can't see you. I don't get a feeling of where you're at. So I'll be glad when this craziness is over. So some surprising points for some of you, that 75% of people with addiction are going to recover. Most of what we need for recovery-oriented system of care is already out there. We just need to connect it. And we need to identify those assets, those community assets of recovery. If you're out in Bodunk, Manitoba, and your town's big enough for a gas station, chances are you've got a community of recovery, whether or not you know it. You've got some kind of a mutual support, likely AA, but you still have a community of recovery, and you probably got at least 9% of your population who are in recovery, and they, folks, are resources to you. Recovery coaches are basically connectors to the person with addiction, to treatment, to the community of recovery. And folks, we all need each other. We don't have to fight. We can get along and we all benefit. Thank you very much.
And Ray, thank you very much on behalf of the conference and Addiction Studies and CACCF. Thank you very much.